Thank you. Good morning, everyone. Today we'll be covering obsessive compulsive disorder. Cognitive affective research paradigms have emphasized dysfunctions in processes that might lead to increased concern about harm. For example, increased sensitivity to disgust, evoking stimuli, and excessive performance monitoring, or that might lead to an inability to control response to such concerns. For example, impairment in executive functions such as response inhibition and excessive stimulus response habit formation. A range of impairments in patients with OCD have been observed in neuropsychological studies, including altered executive functions such as altered cognitive flexibility, planning, working memory, and response inhibition, and alterations in disgust processing, fear extension, reward processing, and emotional regulation, among others, have been reported in affective studies. Now, mechanism pathophysiology of OCD, the neural circuits involved, the defect in cognitive and affective processing in patients with OCD could be mediated by alterations in specific neural circuits. Such models have integrated data from neuroimaging and cognitive affective studies by hypothesizing the involvement of parallel, partly segregated corticostriato-thalamocortical circuits, that is CSTC, that are involved in sensory motor, cognitive, affective, and motivational processes in OCD. Functional and structural imaging studies support this hypothesis by demonstrating in alterations in several brain regions that comprise these circuits in patients with OCD compared with healthy individuals. Other models have also implicated alterations in frontolimbic, frontoparietal, and cerebral networks. So the neural circuits involved, they include sensory motor CSTC circuit, stimulus response with habitual behavior, dorsal cognitive CSTC circuit, working memory, which is involved working memory, planning, emotional regulation, frontoparietal network involved in coordination of cognitive control, ventral cognitive CSTC circuit involved in response inhibition, ventral motivational CST circuit involved in stimulus outcome based behavioral motivational behavior, and frontal limbic circuit, which is involved in fear extinction. Now, neurological insults and OCD. Certain neurological lesions can cause obsessive compulsive disorder. In addition, subsequent research has identified obsessive compulsive symptoms in patients with neurological conditions that affect the basal ganglia, including Sydenham, chorea, and neuroacanthocytosis. OCD can also be sequelae of neurological lesions that affect other areas such as frontal lobe, suggesting the frontostriatal circuitry could play a role in OCD pathogenesis. An early meta-analysis using activation likelihood estimation combined the results of 8 studies and demonstrated increased symptom provocation induced activation of ventral frontostriatal and temporal regions, including the hippocampus, in patients with OCD compared with controls. A more recent meta-analysis using signal differential mapping demonstrated increased activation of the bilateral amygdala, right putamen, orbitofrontal cortex extending into the anterior cingulate and ventromedial prefrontal cortex, middle temporal cortex, and the left inferior occipital cortex during emotional processing, induced, for example, by exposure to disease-relevant stimuli, particularly in OCD. Now, the molecular mechanisms involved in OCD. Early findings that OCD responds selectively to serotonin reuptake inhibitors has led to substantial attention on the serotonergic system. The involvement of dopaminergic system was highlighted after patient responded to augmentation of SSRIs with dopamine D2 receptor antagonist, among other data. Whereas the more recent studies have focused on the glutaminergic system. Strong evidence suggests a central role of dopaminergic system in Tourette syndrome, which many would consider to be one of the key OCRDs, obsessive compulsive related disorder. Supporting the role of dopamine in OCD, some studies have supported an association between variants in catecholaminergic genes, including COMT and OCD. And molecular imaging studies have suggested alterations in specific dopaminergic receptors, such as a decrease in striatal dopamine D2 receptors in OCD. Glutaminergic neurons originating in the prefrontal cortex have a key role in CSTC circuit. With these neurons projecting to the striatum, cerebrospinal fluid and magnetic resonance spectrography studies have indicated alterations in glutaminergic metabolites, confirming that this system might have a role in OCD, although not all findings are consistent. In addition, variants in glutaminergic genes, such as SLC1A1 and GRIN2B, are associated with OCD, and meta-analysis of genome-wide association studies in OCD have implicated several glutaminergic system genes such as GRID2. Other neurotransmitter and neuropeptides have been implicated in OCD. Molecular studies could ultimately also allow delineation of pathways from genetic and environmental risk factors through to alterations in brain imaging and other possible endophenotypes and to different stages and subtypes of OCD. Now, coming to the DSM-5 diagnostic criteria for obsessive compulsive disorders, obsessions. Presence of obsessions, compulsions, or both. Obsessions are defined by 1 and 2, that is, recurrent and persistent thoughts, urges, or impulses that are experienced at some time during the disturbance as intrusive and unwanted, and that is most individuals cause marked anxiety or distress. The individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thoughts or action, that is by performing compulsion. Compulsions are defined by repetitive behaviors. For example, hand washing, ordering, checking, or mental acts, for example, praying, counting, repeating words silently, that the individual feels driven to perform in response to an obsession or according to the rules that must be applied rigidly. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent or are clearly excessive. So OCD symptoms, the contamination symptoms, concern about dirt and germs among others, and compulsions include washing, showering, and cleaning. Harm-related symptoms, concern about harm, obsession is concern about harm, and compulsion is checking. Acceptability symptoms, obsessions such as intrusive, aggressive, sexual, or religious thoughts, and compulsions including mental rituals or praying. Symmetry symptoms, obsessions include symmetry concerns, and compulsions include ordering, straightening, repeating, or counting. Hoarding symptoms, obsessions include hoarding concerns, and compulsions include hoarding behavior. Now, the comorbidities of OCD. 90% of respondents with lifetime OCD meet the diagnostic criteria for another lifetime disorder. Most common were anxiety disorder, mood disorder, impulse control disorder, and substance abuse disorder and tic disorder. 79.2% of cases, OCD begin with comorbid anxiety disorders, whereas OCD was about equally likely to begin before or after a mood disorder and begin with comorbid impulse control and substance use disorder in 92.8% and 58.9% of cases respectively. Now the OCD assessment. Comprehensive assessment is the first critical step in diagnosis and management of OCD. Goals of this assessment include making an accurate diagnosis, gaining information on presenting obsessive compulsive symptoms, determining symptom severity, and assisting with selection of relevant treatment targets. Core of this assessment is to take detailed psychiatric history and examining the mental states. Structured diagnostic interviews include structured clinical interview for DSM-5, that is KID-5 over adults, and anxiety disorder interview schedule for DSM-5, that is ADIS-5, which include both an adult and a child or parent version. Mini International Neuropsychiatric Interview, Mini version 7, is a shorter instrument, has also been revised in accordance with DSM-5 and is available for use in adults and children or adolescents. Y-box and children's Y-box are widely used. Dimensional DY box allows more detailed assessment of OCD symptom dimension and their severity. Now, we'll include a few two of cases. 15-year-old child studying in grade 10 came with his parents. Since last 6 months, he felt compelled to do certain things in a particular way, had bad thought about people, including people he loved, and that made him guilty. While writing, he would feel he has made a mistake, so would erase and start rewriting. Due to this, he could not complete his papers, was stressed as his boards were near, had to wear his night dress in a particular way, and if it went wrong, he had to redo it to feel correct. Eventually, he started losing interest in his hobbies and felt sad most of the time and felt helpless. He said he tried to resist these thoughts, but it never helped. His grades were deteriorating and he wanted to be alone most of the time. Also picked up lots of weight during lockdown. There were no other comorbidities, and the family history of OCD was present in mother. So diagnosis, it was OCD mixed with secondary depression, included aggressive obsessions, pathological doubts, orderliness, significant time interference, distress, resistance without much control. So, in the treatment or management of this patient, he was started on fluoxetine 20 mg. He was having GI side effects and lots of yawning. So, he was shifted to 50 mg fluvoxamine and then to 100 mg. Response was good for OCD treatment. To reduce anxiety, a low dose of clonazepam 0.5 mg was started, which was tapered to 0.25 mg. And CBT was also. Thank you.